the sono image, then what you're going to see? You're going to see this. This is bladder here. This is bladder. Okay, so this is gynaectasia. You need to remember. Now let's move on to the subscripted uterus. Subscripted uterus means it's not completely septated, subscripted. So now let me give you the anatomy of this. Okay, so now look at the inside the uterus, the myometrium. So this is myometrium. The myometrium is tending to go down to make the uterine cavity into two compartments, but it couldn't do that. It is partially done. That's why it is known as subscripted. And as a result, look at here, the endometrium. Let me use the red pen. Yes. This is endometrium. So then what happened to the endometrium? Endometrium will show you a butterfly appearance. Okay, endometrium is endometrium has a butterfly appearance like a two wing, and you can see it better in transverse view through that level, upper part of the body. You will see the endometrium is wider and the two wings are like this. And you will see the myometrium. Myometrium is let me give you the different color. Myometrium is hypoechoic, and automatically you can see the myometrium is trying to go down through the endometrium. You can easily see it. Look. But question, is it okay that patient can have a regular period? Yes. Patient can have pregnancy? Yes. Baby can have a full term? Yes. Because there is still adequate area. Adequate spaces are in there. So there will be no problem. And now patient will have no complaint, nothing. Even patient may not know whole life that she has subscripted uterus. So now sono appearance. Sono appearance, how does it look like? If you scan through the fundus, you will see one fundus. But if you scan through this level, then you will see what? You will see in transverse view, Look at the endometrium. So this is myometrium and this is endo. Okay, make sure you know that this is better seen in transverse view. Most of the anomalies are better seen in transverse view. Okay, we got the idea. This is transverse. Okay. Okay, now biconduit uterus. In biconduit uterus, you will see cornua, means horn. The uterus has two head. So if the uterus has two head, how does it look like? Two head means two fundus. So now how many fundus here? The two. That's why biconduit. And now okay, so now you can say, oh, that means the septation went down too far, close to the cervix. I will say yes. That's why the body and fundus are separated. So now these are the fundus. And then body. Body, and look at the endometrium. Endo, but one cervix. One cervix and one vagina. So this is biconduit uterus. Now, one thing I did not draw yet. What is that? Fallopian tube. In this situation, keep that in mind. How many uterus is there doesn't matter. Fallopian tube is always two. Fallopian tube is always two. You feel like there should be one fallopian tube here and here. No, 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 no. Because developmentally two paramesonephric duct up above the fusion, there is only two tubes, right? So fallopian tube will be always two. Keep that in mind. So now this is biconduit uterus. And if I want to see or prove that it is really biconduit, then I will say yes, try. How I'm going to try? Then I will say, okay, do it in transverse view. In transverse view through the fundus. Through the fundus and through the body. Then what are you going to see? Through the fundus, in transverse view, transverse through fundus, then you will say there are two fundus. Transverse is the best. In size, it will overlap. You may not see clearly. And now, transverse through body. Okay, you will see two body and two endometrium. Okay, you will see it's a body and these are endometrium. So you can see sonographically very nicely two separated body with the endometrium. And now your transducer is that level. Then you go down, 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 and you will see only one cervix. Then go more down, you will see one vagina. But from this level you go up, 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 then you will see from cervix, then there will be separation of the endometrium. And body are two, endometrium two, fundus are two, endometrium, the two domes in transverse view. Okay, so this is now a question. Is it good for the full-term pregnancy? I will say no. Why? Because the uterine tissues are utilized by the two uterus. And the endometrial space will be narrow because the uterine size will be narrow. And when it is narrow, it will provide a less space for the complete full-term baby. That's why they are high risk group. And most of the time you see that if pregnancy takes place, so it can be miscarried. Okay, that's why it is a high risk pregnancy, and they will observe it, they will follow it up until the baby has substantial growth and the lung matured, and they will take the baby out. They will take the baby out. So now, question. If this mom has a ovulation from the both ovary, ovulation from the both ovary, is it possible to get the two baby in the two endometrial cavity? Yes. You know, sometimes it happens. Sometimes it happens, unfortunately the two ovaries are working and they get stimulated and they ovulate and there might be two babies. It is possible. And what happened at that time? There is a chance of miscarriage because the accommodation problem. Okay, so this is biconduit uterus, we understood. So now let's go over the uniconduit. Uniconduit. Uni means one. Uni means one. That means when only one mesonephric tubule means Mullerian duct, paramesonephric tubule means one Mullerian duct is developed. That means if there is only one Mullerian duct, so then what's going to happen? It will form the uterus, small uterus. Okay, it will be a small uterus, a single Mullerian duct, and this is a single fallopian tube and small uterus. Small uterus. Then you will see the small cervix and the narrow vagina, and the body capacity, small body, the capacity is smaller. So as a result, the accommodation will be small, baby will be small for gestational age, or miscarriage. Most of the time it gets miscarriage, pregnancy is not possible. If there is a pregnancy, high risk pregnancy, and it has to be followed up until the 32 weeks of pregnancy till the lungs are matured. Okay, if the lungs are matured, so then they will do the C-section and take the baby out. Now, how can I diagnose that this is uniconduit? Normally, it's very hard. It's very hard to diagnose because it looks like a normal uterus. And it is diagnosed that a small size of everything, and having more miscarriage, then they will do the hysterosalpingogram. Then when they will do the hysterosalpingogram, then they will say, okay, there is only one tube. What happened to the other tube? It did not develop. What does it mean? It means uniconduit uterus. But make sure ovaries are always 2. Ovaries are always 2. But fallopian tube is only one side. And ovary ovulate every other month. That means this woman has a chance of having conception more delay. Why? Because if it is January, March, if the ovulation takes place here and the next month the ovulation will take place here, but there is no fallopian tube, so chance of conception is 0 here. Then next month, that means April is here, then May, there is another chance here. Okay, so this is the situation, and normally we cannot see the fallopian tube sonographically unless it is dilated due to some obstruction. Okay, so now we understood that sonographically in transverse view you will see the small uterus with the endometrium, small uterus body. Okay, so this is uniconduit. Now, uterine didelphys, this is very interesting. Why it is interesting? Because both the Mullerian duct or paramesonephric duct, they said each other that no, we're not going to fuse each other. We will grow two as a two uterus. Okay, so now two Mullerian duct, draw the two Mullerian duct. Okay, now they will grow by themselves. How they will grow? They will not fuse each other. They will start dilating at the center. Okay, let me make it a little better. Okay, so now at this point they will make their own cervix. Okay, and they will form the endometrium here. Then they will okay, so now what happened? There are, okay, make it a little nice. So there will be two fundi. There will be fallopian tube, two. Even though there are two uterus, doesn't matter. Fallopian tube will always be two because the ovaries are here. Okay, and the ovary will be connected by the ovarian ligament. Ovarian ligament, and there will be two cervix, two body, two fundus. This is body, this is body, this is cervix, this is cervix. Now once there are two cervix, keep that in mind. The vagina will not fuse each other. It will be his, whose. One vagina for one cervix. And two vagina for two cervix. So now what happened now? Everything is two. That's why it is called didelphys. Everything's are two. Two uterus, two vagina, two fallopian tube. Why? That they did not combine each other. They wanted to grow by themselves. Now tell me, what's going to happen? This two size of this two uterus will be bigger or smaller? It will be small uterus. Small, and small uterus has a small total capacity. And there will be two vagina. There will be two vagina. And it is side by side placed. Okay? And the vagina will be two vaginal opening in the front. And believe it or not, this two uterus may be pregnant, and with the two different partner. And this two baby may be from two different father. Okay? So this is uterine didelphys. So sonographically, what we see for the fundus, let me draw the fundus first here. Transverse fundus. You will see two fundus, two fundi. Then you will see transverse body, okay, there will be two body, two bodies. Then you will see the transverse cervix, okay, there will be two cervix, two cervixes, and there will be transverse vagina, okay, and there will be